I'm Benton-Lee, and I've been a nurse for almost 20 years. It's getting pretty close. I think in December it will be 20 years. I started out in the ICU, so I was one of those new grads that went directly from grabbing her degree into the ICU. I am a rural Kentuckian. I am African American. I grew up in an area that was very poor. It was very desolate. The healthcare system was not very great. My family owned a nursing home, and so my great-grandfather started the nursing home back in the 50s when it was just for colored people. And then in the 80s, of course, it transitioned to everybody. And so I was always around healthcare, even though I didn't understand my family kind of ran this nursing home. I guess I just thought that I was there. So I always had this affinity, this attraction to nursing. Of course, I had to go around the world to get there because I developed an English degree. I taught business administration. And so I went back later as a second degree nurse and received a nursing degree, and very passionate about it. I realized that that was my purpose, was nursing. I found myself in a situation where I was seeing more and more of my loved ones pass away from preventable illnesses. For me, healthcare is strictly personal because I wanted to be able to go back into my community and make a difference. Felt like some of it was lack of education in my community, but also lack of resources. But then there's also discrimination. I was in an area, in a hospital, in an area that has a majority Caucasian population. I was supposed to go into a room and start an IV, something that I did really, really well as a nursing student. When I went into the room, he sent me out. He said he didn't want an N-word to take care of him. I was so disheartened because I didn't expect that in a healthcare environment to be called outside of my name. I didn't know how to react. I talked to my clinical instructor and she said, this is part of the process. In one sense, that's true. In another sense, I don't ever think a nurse needs to take any type of abuse. We had a conversation with him and he still kept throwing the N-word around. And then he said that he had a fear that I was going to give him N-word blood and that he didn't want to turn into N-word. I was in the process of crying. I was trying to be strong. I was with my peers and I was hearing my instructor saying, this is part of the process. Her experience was different than mine. In her mindset, being a nurse that's worked med-surg, that patients call you bad names all the time. You know, they will yell at you, they will scream at you. And she didn't see the N-word as being different than maybe being called, a bad word or called a derogatory term for a woman. I don't think she saw the difference in that, so she didn't know how to handle it. But I also think that in her lack of knowledge, she was uncomfortable. I did end up drawing the blood, first stick, after multiple people tried him and couldn't get it, even experienced nurses. And he said, N-word, you did a really good job. I'm surprised. When you're doing your job and you're trying to save lives, I always say nurses, we save lives, and someone cannot see the fact that you're trying to help them and they can only see that you're a Black person, it's detrimental to your spirit. Worked surgical ICU for many years and loved it. I did pediatric ICU for a few years in cath lab, and then I decided to try my hand in management, and so I went into administration. My biggest hurdle ever was trying to climb the administrative ranks in nursing. I became a manager for sure, and that was extremely hard. And then trying to go from manager to director was almost impossible. Some of the individuals that I trained and provided education to moved up ahead of me, even though I realized that they didn't necessarily have the skill set. I think it was because I was a person of color. Some of the racism I faced was from even my own nursing staff. Working peer to peer was okay, but once I became a leader, it was more difficult taking direction or getting feedback, even receiving performance evaluations from a person of color. And even if I communicated things the same way as someone else, they would say I was aggressive. I was the highest paid nurse manager because I had been there so long. I had watched several of my peers that did not have the same qualifications moved up. What I learned to do is that continue to apply. And when I didn't get the position, I would ask for a follow-up meeting. And in that follow-up meeting, I advocated for myself and I asked for them to explain why I didn't get the position. Told that I didn't have executive experience. And I said, I do have executive experience. Remember this notebook? I would create a portfolio of things that I've done. And I gave it to them before the interview. And I would slide the extra copy that I kept across the desk and flip through the pages. I said, this is where I had executive experience doing this. This is where you sent me for training for executive experience. This is where I trained the last two individuals who moved up with executive training. I wanted to make them know that it was blatant, that there were alternative reasons or why I wasn't being moved up. No corrective action in my chart, no attendance issues. So why didn't you move me up? I managed a surgical and trauma unit for about 10 years at an academic medical center. And now I have shifted, which is pretty exciting. I've shifted to academia. I do a lot of education to graduates, so doctoral and master level nursing students. I also run a nonprofit organization here in Kentucky it's called Cultured Remedy, where we do community-based education. Seeing what I saw growing up and the health disparities kind of prepared me for this. I go in and I provide intercultural development training. So I will test them to see where their current intercultural development level is. We'll talk about unconscious bias because it's so important. A lot of times people say I'm not racist, but then they have behaviors that exhibit it and they're not aware of it. I look at where they are as far as being monoculture, focus only on their culture, all the way up to worldviews. And what I tell people is that you have to get to the point where you can adapt to other cultures and still be true to yourself. I'm rural, I'm Kentuckian, that's who I am, that's part of my culture. However, I have to be able to learn to interact with people that are different from me. If I'm going into a room with a patient that may be of Muslim descent, I need to be able to interact with that patient in a way that contributes to their quality of healthcare and they're getting some value-based care, but we're also building a relationship with each other. I didn't take on their culture, I still have mine, but I'm interacting very well between the cultures, and that's why intercultural development is so very important. I'm so nervous before I conduct any training. And the reason why is because either three things will happen. People will receive it and they have that aha moment, or they will be very confused and maybe they'll reach out later to me to ask questions. And those two things I'm very comfortable with because I can adapt and adjust. The third category is what I call the scary category. I'm a small, petite woman, and I go in, and a lot of times I get a lot of aggression. Usually it's white males, but not always. And they're very aggressive towards me. And I kind of have to stick to my guns and be very polite, but be steadfast because I know this stuff. Just because they disagree with me doesn't mean what I'm saying is not true. I usually start my presentation with, this is not your diversity training from the 90s. I always felt like in the 80s and the 90s, diversity training was very polarized in that it's black against white, heterosexual against homosexual, male against female. I don't do that. I feel like we need to start bridging gaps. What I try to do is paint the perspective in the beginning before I even get into the heavy stuff, so that I am framing the discussion to try to eliminate some of that aggression, but sometimes it still happens. What I do want them to understand is that even though we're focusing on this minority group, whatever it is, of this vulnerable population, there are things that happen in all groups, but today we're focusing on this group because they have the greatest hurdle to overcome. And so when I start that, sometimes people hear it and they try to take that perspective. Initially during the presentation, she was very kind of stoic, very quiet, but I started to see her come down. As we were starting to talk about things, she was starting to internalize and started to think about her experience. I felt like at times that she might have been weeping. I couldn't quite see because she was very guarded. At the break, I talked to the staff at the organization that I was working with to kind of talk to her to feel her out because she may not feel comfortable with me coming to her. They came back to me and said that she feels very attacked, that I was attacking her, even though everything that I was saying was very general to the group. She was at times weeping, but by the end of the session, she became so upset and screaming and yelling at me. We were talking about the differences of care for racial minorities and how African Americans tend to fare worse with pain. There's a recent study out that healthcare providers still believe that Black people don't have pain. And so we were discussing that, and she became so angry with it because she believed that that was true and that's what she was taught, and I was wrong. And at that point, her frustration was that I was incompetent. And sometimes as a person of color, even when you're right, people want to make you feel like you're incompetent. The first thing we have to do is be self-aware of who we are. In some environments, I'm privileged. In some environments, I'm oppressed. And we have to be aware of that. And we have to be able to look at who we are and our biases and make adjustments. I think healthcare has grown so fast and it's boomed that we're so busy that we can't connect with people on a level of the heart. Most of us went into nursing because we were passionate about taking care of people. It's important for us to take our leadership and our nurturing to change healthcare in a way that we connect to people on a very personal level. I call it the village mentality. So as nurses, we have to look at ways to create social justice, nurse to patient, nurse to nurse, nurse to provider, and within our health systems. And we can start small and build up. As nurses and healthcare providers, we expect for the patients to come to us. Some communities, they don't know when they're ill. They're used to using home remedies. In order to, one, change racism and to change healthcare reform, we're going to have to go back into the communities. We're going to have to be seen. We're going to have to be heard. And we have to be their friends and their family. And we have to show compassion. We can't sit in our pretty little $1 million buildings and say, they need to come to us because they may not be able to afford it. I think the biggest thing is accessibility, and it has to look much, much different. The pretty buildings is equality. Equity is going to be community-based, and we need to provide equitable care.